Safety means that the buildings, the constructions, the doors, the access, the ramps, the lifts, all of them are checked and they're safe. Then we come to the security plan. The security plan assures us protection of our property, protection of our own valuables, protection of our own self, and every single item in the hospital. So many staff have been interdicted because something very expensive has been lost in the hospital. Who took it? How do we know about it? There is a hospital I worked and a patient had come to the hospital with around 1,000 USD and the money got lost. How do we assure the patient that when they come in, they're going to get out with their valuables and everything in place? So we need to have those security plans. Then another plan is the hazardous material protection from them, radioactive rays, the waste that is taking place. You're not coming in, getting out with infection. The waste that is produced is going to be directed and disposed in a proper way. And that's a whole. Then we have fire safety. Let me tell you the truth. If you're in a hospital and it does not check their fire safety preparedness, if today we get fire, I tell you we will lose several patients, including staff. Look at those newborn unit. Look at those mothers in labor. Look at those in critical unit, renal unit on a machine. If fire breaks out today, what happens? So that's another plan that needs to be put in place. We have the utility systems. How safe are the waters? How are CCTVs being checked at? Are they ready for use? How is oxygen supply? You might find oxygen plants are not checked. Somehow, if the hospital has not gone further to that checking, so that one day oxygen plant is blocked and you have a patient in critical care, what do? We lose a patient. These are reports you won't see. If you work in a hospital, you will know the patient errors that we encounter every day. And when you've gotten such plans in place, I've not finished all of them. There is emergency preparedness. How ready are you if there is a disaster, terrorism in a facility right now? What do you do at Kenyatta National Hospital? Where do you evacuate to? Where do you take those renal patients to? Do you have a plan? Have you tested it?
Because what are we saying? That essentially, if somebody, what we're talking about is that two people, let's just take KNH for example, and this cuts across. We're not even saying just public hospitals. Even in a private hospital where a woman was strangled, the circumstances around why she was in hospital in the first place is another story. That's another topic that can be discussed apart from here. Now here where we are talking about this safety and security, that somebody can enter into a space deemed protected and safe and take away life in a place where it's supposed to be preserving life. I think that's just the oxymoron of the year. But then look at KNH, the manner in which these two individuals were killed, their throats were slit end to end.
And that's not a 1 minute thing.
That's an intimate crime because you have to come close. You have to come close. So when this is taking place, where are the people where is even this alarm system? Where is the security system that should at the very least be in close proximity to this area? And if it can happen in 7B, it can happen anywhere.
Yeah.
Twice in 5 months. And we are saying, because the things that you guys are telling me over the break, then no wonder. If it can be turned into a marketplace, then of course it can be turned. What are we saying?
So this is what I know about the case where the strangulation has happened. They have a group of hospitals. There are a group of hospitals. They have a facility, I think, in Mombasa. I think one in Lavington, and the one in Kileleshwa, and another one in Westlands. The one that I know of. Yeah. The one that I have visited at Lavington, each room, each ward has a CCTV. The same brand of the same hospital. So it's so absurd now that a similar incident happens in one of the branches that probably does not have the same standards as the other establishments. So it's a little bit off. So it could have been either premeditated activity from long time, you never know, or just someone probably coming into the hospitals and masquerading as a clinician for such an incident to happen. Because I know from when they were trying to explain to us how the facilities work, they were new at that time, that you'll get admitted here for persons who are very, very extremely suicidal, they'll have to be monitored. Or persons who need special care, they have to be monitored by CCTV. So that means there is a station where someone is watching how patients are doing this particular kind of cases. There are special cases of patients. So for this patient to be locked alone and for someone to probably access their room and strangulate them, there is more that beats logic. There is an issue of access breach. by other persons or persons inside the facility.
So, Dr. all this is clearly systemic neglect. Are these cases isolated? Because this is what has been, so far been reported. And the argument can be, there could be others that go unreported in other facilities
Elsewhere.
outside key towns, for example. You go deep in the villages, you'll find maybe there are things. There's a case in Kisi,
Yes,
I
that one, I remember.
Kisi of that Mzee,
Yes.
who was almost poisoned. And it was a family feud, but he managed to escape that. Access to even food and water, that somebody can walk into a hospital and poison a patient's food. It's serious. Now, here, are these isolated incidents or cases, or do they point to a pattern of neglect, a pattern of understaffing, a pattern of how we treat safety in this country that goes beyond hospitals? It's in schools, it's in every public space you can think of. Is this pointing to a pattern?
Yes, it does point to a pattern whereby we have not been very keen on the standard of care that we provide our patients. We just put up structures and we say, come in and we'll see you. So, but the system of a process of accessing care has not been controlled in a way to assure persons of safety. And safety in healthcare has so many elements that bring about now the experience of quality. So from timeliness, from other persons breaching, from other persons masquerading as doctors and doing procedures that they're not trained to do. So those standards have not been well established. The laws that we have, they do provide a framework that allows the regulators to provide standards for checking every regular period to assure persons of safety and quality. But this probably has not been implemented. Hospitals renew licenses every year, but there's probably no one telling them, give us a report of this and that. Or do random checks to come and check whether this and that is working, like the fire escapes, check whether everything is well in order as regards your drug management. Now, if this is not well done, then you have an issue with the regulators. Because the regulators keep licensing facilities to operate as usual.
So in this case, who's responsible? Because this has now happened. Who is responsible to make sure the risk assessment is properly done? The things you itemize and say these are the things that facilities should done. A patient is going to hospital, they are sick. They are not thinking fire escape routes, they're not thinking CCTV. They have come to hospital for just care. They want to be well. Who then should be ensuring in giving these licenses, like you're saying, periodical checks, risk assessment checks? Who is supposed to be doing this?
Every institution must have all these plans put in place and somebody appointed to do the risk matrix. This risk matrix should be feeding to a central area, and this is what is missing in all our facilities. And even those that are able to put these risk registers in place, they're properly put for auditors. When you're coming to our desk, here we have it. That is why this case will happen in February. Did a root cause get done? Do we know what caused this first death properly as a hospital? Then did we mitigate it? Did we take an action? So every head of department in hospitals must do their risk analysis. These risks, all of them, should pull into the hospital register. And every month in those properly accredited hospitals, sit and review their registers and see which risk has penetrated. So what is the root cause? What are we going to do? What will we do different? That way, hospitals are proactively managing. I have seen a facility that you are talking about a murder of fellow patients. There is a case that a doctor and a doctor friend, you are coming to see this doctor and they're poisoning him to die.
Emily.
A doctor to another doctor?
A doctor to another doctor. They are enemies. These are cases that are happening. So patient safety is not only affecting patients, it's affecting the public. Our public behavior is in the hospital corridors. So we need to up the game.
So then if the hospital is not doing that, who regulates? Who will check whether you have everything, you've put everything in order and patient safety is a top priority? Who does that?
This organ that's certifying
Regulators.
hospitals. This regulator that is regulating hospitals every year, we
What is
certify
their
to
name
operate.
again?
There are
called who?
several. So you can have internal regulation and external regulation. So internal is that you are expected, you as an institution,
CEO.
to have internal ways
The
to
board.
do it. That's the CEO and the board. And the CEO has checks and reports from each department on how things are working. That's internal. Then there's an external person who checks whether they're complying to those things that you've set. And then there's someone else after the two, external and internal, who now does
Who are these
overall
external?
accreditation.
Who are these external?
We have the one that gives the license to the facility, the healthcare facilities. That's a Kenya Medical Practitioner and Dentist Council. We have the Pharmacy and Poisons Board. We have the Clinical Officers Council. We have the Nursing Council. So all these institutions have standards that they should enforce. So they're supposed to set and give them to the facilities that are already in operation. Go do that you're supposed to do.
Before
and then file reports.
before checking and before licensing, do they visit these facilities periodically? Not with the intention and purposes of issuing a license. Because if I open a hospital today, I will ensure fire extinguishers are everywhere. Everything works out well. It's clean. The beds are looking good because I want to get the license. But soon as I get that license, a month, 2, 3, a year down the line, because I know I'm going to renew these after 1 year, then our behavior, like you're saying, Emily, is because I want this license to be renewed, I will again go back, clean the place, make sure the fire extinguishers are there. So before issuing the license, what is the procedure? Do they go do physical visits?
Now, the physical visits happen. Because by the time you're getting to pay for that license, you're already set to start seeing patients. There is a county inspection that is supposed to be done, and then after that report is filed to the regulator, then the regulator is supposed to come and visit. But it appears there was a gap over some few years whereby the county reports will be filed in, and once it's filed into the regulator, you just get a license issued. So now they're trying to have the regulator also visit, because some county governments, some officials, not the county government, some officials in those county units that are supposed to go and inspect, they just take whatever bribe and say you have this equipment, and sometimes they organize how to get things from a neighboring facility for the show of that particular day of inspection. So that now you have good beds, you have everything, fridges, everything is all there. After the visit, you return back what you had rented. You're back to status.
And that's what has brought the external regulators taking shape. That's how KEBS has taken charge of certifying and accrediting hospitals. That's why serious hospitals have gone further to get Farm Access Safe Care. That's why others have gone further to get COSASA, an accreditor from South Africa. Others have gone further to go to Joint Commission, which is very serious. So that's why I said a hospital that is serious will go to these external people because there is a gap internally from the ministry. Yeah.
And unfortunately, the tag that we are seeing now is that these hospitals that would be very serious, according to what you're saying, then fall in the private sector.
Absolutely.
And why is that?
Because it's competitive age. If I want to attract patients, and health sector, we want to agree like it's a very highly economic turnover place. So if I don't go further to get accredited, I won't attract patients to my facility, and hence I won't have systems in place. So because internally government, it's not a headache, they go extra ahead to just have safer, proper systems.
Because we know that people will go to the level 6 referral hospital
Absolutely.
anyway. You will never go one day and find that there are only 2 people in the hospital. They're there.
Well, on this one, I'd want to add that we do have a Kenya quality model for health.
Okay.
Yeah.
That's a framework that's supposed to ensure how healthcare is supposed to be experienced from level 1s to level 6. It's all there with checklists of things that must be put in place and followed through and reported on regularly. But now the implementers of this model, the quality framework, they are very few probably.
No, there is no oversight.
And there is no
over
oversight.
the
It's
model.
someone assigned to do regular reporting of that mandate. So all persons want is, have you paid your license for the year?
The
Life
model
goes
is
on.
there and it's
Life
really
goes on.
nice. But
So we need more capacity to ensure that as much as healthcare is happening, checks of what really is transpiring in those places are being undertaken and reports are being filed.
There's a sad story here where I once dealt with an individual case of a hospital somewhere in Nanyuki.
Yes, yes.
And what was happening is, and this is worse, where patients were actually being raped in wards by quote unquote staff, and this particular staff doctor. By the time the case is coming to the regulator, and this is what I found out. You know, we have very, very good documents in this country, policies, risk assessment, records. We have that on paper. But the saddest part of this story was this fellow, who was also the owner of the hospital, actually ended up calling one of the regulators to bribe them.
To clear their name.
Yeah.
To clear the name, because the threat was your license will be revoked. So again, here is a question where there are people who will sit in an office. They will not do physical checks. They will not even bother. You want a license? How much money do you have? Bring the money, give you the license, go and operate.
God.
So it's almost, we need a regulator of regulators.
Yeah.
Well, we just need a person of good moral and ethical
Integrity.
standards
Where?
to make sure that his
Where?
staff are doing that.
In the hospital?
Some,
No,
some
in
of
the
these institutions, they do not have
Oh, in the
such
country.
kind of
Emily
mix
says
of
in the
persons.
country, not in the hospital.
The sad one is this one. Sadder like yours, persons put on a white coat and they act like obstetricians. All they want to do is to inspect women.
Eh?
What?
They just want to enjoy inspecting women, and they fake that they're doctors. So just get a white coat, say you're so and so, and somehow over time
Okay,
you
hang
just
on. So when
start
you're going-
masquerading, so you just saying
Dr.
I want to go bed
This is
by
a
bed
real
inspect.
case.
Dr. Mundia.
Yeah, stories
Dr.
that
Mundia.
happen, real stories, weird ones.
Dr.
So
Mundia.
clinicians are also affecting what you're experiencing in there.
Dr. Mundia.
Yes.
When you go with the white coat and say, I am so and so, there is a nurse's station. They usually go there to get files. I think. It's
Yeah.
not just from the movies. It happens. They go there to get files and somebody will say, yeah, Dr. has come, etc., etc. You are known. Whether you are a doctor on rotation, whether you are a visiting specialist, whether you are a resident doctor, they know you. So how is it possible that somebody...
It is
How
possible
is somebody
because
just
you
walking
just
around and put
bypass
some,
the station.
that means Ndu can walk into the referral hospital today, and if I have a white coat
and a name tag, you'll
and
be
a
let
name
in.
tag, and I just look like I know what I'm doing, people are
it's all
going to be
about,
letting me in.
I want to go there, I'll do that.
How
You
did
just say
how
hello
did
to the
Dr.
nurse and
Mugo
you
get
pass by.
away? The fake doctor. How did Dr. Mugo get away with the things he did to women? In a clinic, he had a license.
You are speaking about something that personally I am a nurse, trained, certified, can practice, and I have been admitted by my son in hospital, by my colleague. And you wake up at night and this guy, I have written that story on my LinkedIn page, and it's a very sad story. And when you report to management, they think you are sick. There is a way women are purported to be imagining things when rape happens in hospitals. This gynecologist did, we can't believe you. This radiologist, you see the scan they do. You can't imagine. So the safety of patients in the hospital is an issue that really needs proper overhaul of system thinking.
And according to what you're saying, proper divine intervention. Honestly,
Yeah,
because
well,
what we were, the
We need
direction
all
we're
this to be
heading,
brought out so that we experience the best quality as it should
Absolutely.
be.
and that's why we can't but talk about them.
Absolutely.
That's why we must have the conversation. And that's why we do this on the Situation Room. This doesn't end here. We're going to talk about this again. We'd like both of you to join us again at a further date, because this doesn't end. There's still people in hospital today who are under the threats of insecurity.
Absolutely.
And we can't stop talking. Thank you for joining us to close out this conversation this morning. And we look forward to the next one. Thank you, everybody.
This is the Situation Room, the only way to start your day.